Hello, I'm Natesa Pandian, a cardiologist now working in United States. I had the opportunity this week to provide one or two presentations or lectures at this WCCICC conference. And today, one of the topics I covered was hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is a heart muscle disorder of genetic origin, which in many people may not manifest with all kinds of symptoms, and people sometimes can live long years without any problem. But there is a certain proportion of patients, what we call a cohort of patients, can develop major problems, such as cardiac arrhythmias, sudden death, or sudden cardiac arrest, embolic manifestations, and a host of symptoms. The symptoms in hypertrophic cardiomyopathy are pretty vague, like shortness of breath, feeling tired, chest discomfort, palpitations. So there's no single symptoms that points out the disease hypertrophic cardiomyopathy. What one needs is an index of suspicion. Somebody comes to you with a family history of a heart problem, you got to think of the possibility of hypertrophic cardiomyopathy, even though there could be other disorders as well. Somebody has a murmur. Most of the time, what one calls the innocent murmur can be recognized, but not always. So in those kind of, or if there is a history of sudden death in the family, and one of the reasons for sudden death is hypertrophic cardiomyopathy. So it's a genetic disorder. So one family member could be silent without any problem. Another family member can develop major issues. So the diagnosis of the condition is critical for further follow-up. As I mentioned, a lot of patients do well for a long time, but some patients develop syncope, arrhythmias, and death, often related to what you call a left ventricular outflow obstruction, where these patients might have a thick intraventricular septum, particularly at the base, and also dynamic abnormality of the mitral valve known as systolic anterior motion of the mitral valve. And that both come together, the thickened projecting intraventricular septum and this anteriorly moving mitral valve producing narrowing of the LV outflow and causing a pressure gradient and high pressure in the ventricle and not enough output beyond the obstruction and syncope. That's why they have syncope, chest pain, these kind of symptoms and all that. One of the challenging things in hypertrophic cardiomyopathy, I'll call it HCM, hypertrophic cardiomyopathy, is that it's a very dynamic issue. Sometimes they may have obstruction, sometimes not. Sometimes after food, there's less obstruction. Before food, there could be higher levels of obstruction. So it's a dynamic disorder. To diagnose that, first important thing, and it starts with the general practitioners, our primary care doctors, to have a suspicion of the disease so that further testing could be performed. The important test that's done in these patients is echocardiogram, cardiac ultrasound examination, which will show the abnormality of the heart muscle and also show using Doppler any outflow turbulence and gradients. So these are all key issues. Once one makes the diagnosis, in symptomatic patients, that might explain the diagnosis. And then there are treatment available. There are certain drugs such as beta blockers, calcium channel blockers, and disopramide. They could be useful in symptomatic patients in decreasing the obstruction. And another issue is that there are certain patients who may be asymptomatic and they may not need any treatment, but someone in the family might have significant problem. So recognition of the disease will help you to do the screening in the first degree relatives of the patient or the subject concerned. Now, so obstruction, there is medical treatment. What if the medical treatment doesn't work? Okay. So you're giving all these medications in different doses, but the patient is not getting any better. Then there are options to relieve the obstruction. One is surgery. It's called myectomy. It's an open heart surgery where you go and resect the protruding portion of the intraventricular septum. Another one is actually placing catheter into the coronary artery and into the branches called septal branches and injecting alcohol into that to destroy the certain portion of the tissue. In other words, you are really producing a controlled heart attack, but not like a major heart attack with all arrhythmias and death, because you are doing it under supervision. And over time, the septum will get fibrosed and shrink, and the obstruction would be relieved. But this is open heart surgery. Another method that's available is what I mentioned, putting a catheter, injecting alcohol. It's called alcohol septal ablation. These are done in selected patients who have not shown improvement with medical treatment. Now some new category of drugs are coming. They are called myosin inhibitors. What they do is decrease the contractility, because in these patients, usually the left ventricle is hyperdynamic. And here, that drug decreases the contractility to a certain extent. It's a dose-dependent one, so one has to try out from small dose and then later on increase the dose and so forth. It's an exciting prospect. Early control trials have shown that in patients who do not get better with a conventional medical therapy, this one would help decreasing the outflow gradient and the patient's symptoms and overall well-being. So that's where we stand in this one. Now, besides what we discussed so far, there are certain subsets of hypertrophic cardiomyopathy. One is called apical hypertrophic cardiomyopathy, where the thickened wall is primarily in the septum. Sometimes there could be a tiny little compartment. There's no surgery or treatment available for that condition, and many patients it may not produce any problem. Some patients it can produce arrhythmias or even an aneurysm formation at the apex. Besides all these things, if certain area of the septum is really thick, let's say 30 millimeters or more, then that could be an indication for insertion of ICD, intracardiac defibrillator, to address the potential problem of ventricular fibrillation or ventricular tachycardia. So it's an important disease. Most people do well, but a small portion, they may not be symptomatic, but some other smaller cohort might have lethal complications. That's why diagnosis is important. We can get some prognostic information based on the Doppler and the 2D echo data, and there are options for treatment. The important thing is to be aware of this disease and suspect it in selected patients. Thank you.